And I'd like to pass the microphone over to Mark Neumann, who will provide us an update on payment and policy updates. Mark?
Yeah, thank you.
Thank you.
Thank you, Tom. It was interesting. This a little bit earlier. We were talking about. I was talking about some of the DOPS analysts about our timing here today in terms of outcomes and data. We were talking about the presidential candidates. It's kind of rare that we hear about their healthcare issues, and of course, the last 48 hours we've heard quite a bit about Hillary Clinton's pneumonia and the healthcare of Donald Trump. So interesting to look at data today and think about their healthcare issues, and of course, how that might factor into the presidential race. So interesting timing. We can go through the slides. There's one topic I don't have on here that I want to talk about briefly, and that is a recent request by CMS for information regarding patients who are being switched or steered, if you will, from Medicare, Medicaid programs into ACA plans. And this has become an issue. It's sort of put renal on the national map because the health of the marketplace plans has been in jeopardy for a couple of years now. A lot of the insurers are pulling out because their claim is that we have much sicker patients going into these programs, and that's undermining their ability to stay in. So it was interesting because ESRD specifically was called up to task on this. They got a separate letter from CMS. There's some concerns about providers steering patients into these commercial health plans. So we're going to continue following that story. As you read, American Renal Associates was sued about a month ago by United Healthcare for that exact reason. Patients in Florida were being shuffled over to their program, to their healthcare plan, and as a result, American Renal was charging much higher rates for that. So it's an interesting story. We're going to keep following that. But let's cover some of the other issues that have been coming up in the last year. If we can go back one slide, we'll talk a little bit about these areas in categories. And I want to talk a little bit about the ESCOs. Many of you are familiar with this demonstration, which started about a year ago. This month, we were expected to hear about some new applicants to this program. The problem has been is that the applicants that have already signed on are the large providers. And there's a lot of concern that the ESCO demonstration and the integrated care approach needs to fit all providers, including small ones. So CMS reopened the application process. We expect to hear this month about new applicants that will start in January. And again, it's the idea is that we want to make sure that all providers can fit. CMS also changed the rules a little bit so that the smaller providers have less of a risk and could, in essence, consolidate the number of patients between these groups in order to allow them to participate. So we'll see what happens this month in terms of new applicants. Next slide. Also underpayment, more particularly underpayment, we of course are expecting the new final rule for the bundled payment rate and quality improvement program for 2017. That usually comes out in November. There is a website here, which is regulations.gov, and it connects directly with the proposed rule, and you can also read the comments that have been given so far on that rule. The deadline for that was August 26th, and there were 336 comments filed, and they're interesting to read through. Cover a variety of different topics, QIP as well as the PPS. So go to that site and look at it, and like I said, we're expecting a final rule in November that will be applicable for January 1st. Next slide. The star rating systems, we've heard quite a bit about this over the years, last few years. It's been somewhat controversial. There have been some changes made, and give credit to CMS for listening to the community because I think these are better than they were when we started. There is a refresh taking place that will be effective October 1st. And again, there's a slide set that you can access here. This is the website that goes through the exact details of that refresh and how CMS has changed some of those things. Next slide. And as you recall, this star rating system, it applies through all healthcare providers. So CMS has created these over the last couple of years for nursing homes and home health agencies and hospitals and most recently for physicians. And the criteria varies quite a bit. I mean, if you're looking at nursing home criteria for the STAR system, it's going to be different than it is for dialysis clinics, et cetera. But in essence, what CMS is trying to do here is provide a reliable, accurate means for consumers to look at these facilities, look at these providers, and determine, whether they're providing good care or bad care. And we're very familiar with this on the commercial side, consumer side, when we look at Yelp and restaurants being evaluated, hotels. So it's the same idea, but it's a little bit different for healthcare, obviously. So, and each facility for ESRD star ratings differ from dialysis facility compare. Some of the same quality measures are being used, but not all of them. So they're separate but connected in that way. And both, of course, are used by patients so they can look at dialysis facilities. And as I mentioned, there's been some pushback, and there was some pushback in the beginning on this, but I think between the collaboration with CMS and providers, it's come around. Next slide. This was the timeline. There was a technical expert panel that was put together in December 2015 to look at the first version of the star ratings, and that included both members of the renal community as well as CMS and some of their experts. There was a preview period, and then the refresh will come out next month, and we'll go into a couple of those details in the next couple of slides. Next slide. So this are the recommendations from the technical expert panel, primarily being able to analyze the data from a baseline versus from a year-to-year. And the importance of that is, just like anything, if you want to see improvement, you want to look at it from where the baseline was versus from a year-to-year perspective. And that's what the renal community had asked for, and that's one of the changes that has been made. In addition, there's other ways of looking at the data and the statistical method of assembling the ratings. And there was some concern about that as to how they were determined. Some changes were made in that regard. And ultimately, I think in general, these ratings are better. And you'll see on the next slide, if we can go to that, I believe that's the next slide. Here's some of the changes in connection with that. Let's go to the next slide. I think this is really the slide that's most interesting, because if you look at the far right, you'll see the number of stars from 5 and then going down to 1. And what you'll see under the new refresh is the number of facilities that come out as 5 stars under the updated system. And you can see in the light blue bars that, in fact, there are going to be more 5-star clinics. There's going to be some more 4-star clinics. And then at 3 stars down to 1, it reduces. So I think this is the adjustment that the renal community wanted to see. CMS is happy with the new process. So I think it all comes out to being a good story for both sides of the fence. Next slide. There's some new measures for dialysis facility compare as well. Next slide. You don't have to read through all this, but I think the key words here are the top headers, which are patient experience survey. More and more, I think CMS is looking at patient satisfaction when it comes to dialysis care. We've seen that with the QIP, which is now where two surveys are now required each year by facilities. We're seeing that with dialysis facility compare here, and I think eventually this is going to trickle down to the 5-star. The message is that CMS wants us to look more carefully at patient satisfaction and tie that in with quality. Next slide. In addition to that, the other changes we'll be looking at bloodstream infection ratio. Next slide. And then also pediatric peritoneal dialysis KQRV. So these will be some additions to DFC. And eventually, as I mentioned earlier, not all of these quality measures go into 5-star, but I think certainly the patient satisfaction piece will show up there at some point. Next slide. Okay, let's talk a little bit about physician practice. The 2017 Medicare fee schedule came out recently in terms of the proposed. This will also be effective in January. Usually this is a good news story for nephrologists. I mean, it's rare that there are many changes in this that have an impact. Usually the amount of dollars stays the same or is, slightly lower. But there is some concern with this proposed rule. This is an article from RPA News. RPA is Renal Physicians Association, and they are looking at home dialysis codes and also looking at consolidating, again, the codes for vascular access. These are procedures, interventions that are done in the interventional center, and CMS is clamping down on bundling some of these codes, and there would definitely be a revenue change for the access centers. So, again, this is in the proposed rule. We expect to see something finalized by November. Next slide. MACRA. Many of the facilities who have dealt with QIP over the years have always said, well, why aren't doctors required to have their own set of quality measures? Well, in 2019 they will, and that's what's called MACRA. This will start in 2019, but the data will begin to be collected next year, very similar to the QIP process where there's always a 2-year time frame between the time that the data applies and the applicability to revenue. So it's going to be focused, obviously, this is a new program. This gets rid of an old payment system, which we'll talk about in a minute. Now, this was a cover from Modern Healthcare that talks exactly about the key issues. But this is going to be a focus on value-based medicine and pay for performance. I mean, that's what doctors will be dealing with in terms of reimbursement from here on in. The ratings will begin in January, as I mentioned. That's when they'll start collecting data. There's a great frequently asked questions site here. Again, I gave you the link that kind of walks through a lot of these questions, explains it very carefully. It's not a government site, but I think it's very helpful. Next slide. So what is MACRA? It's the Medicare Access and CHIP Reauthorization Act. Eliminates the sustainable growth rate, which was the old formula used to govern Medicare pay. Gave physicians a modest payment increase of 0.5% through 2019. And then also beneficiaries will also see some changes in this and see some improvement in terms of reducing out-of-pocket costs. So those are two good things. Next slide. So MACRA comes down to two payment models which physicians can select from. One is called the Merit-Based Payment Incentive System, and the other is the Advanced Alternative Payment Models, which, from what I hear, is the kinder, gentler approach for physicians. Many of them will fit into that model. It's a little bit more, it's a little easier to deal with than MIPS, and a lot of the practices are hoping they fit into that model. But those are the two options that physicians will be involved with starting in 2019. You can see the proposed rule has been released. It was released April 27th. The final rule will be published November 1st. Still a lot of concerns, questions. In fact, there was a story the other day that CMS will grant an easing of physicians into MACRA, slow but sure approach, and allow doctors to kind of work themselves into it. And then January 2017, as I mentioned earlier, they'll be gathering that data. Next slide. So those are the main policy issues. I want to touch briefly on drugs in the pipeline. There's really two big stories that we've seen in the last month. Acurex, which makes Orexia, has not been able to resolve a manufacturing problem they've had with the drug. It's not the drug itself. It's the manufacturing process. So in essence, the drug is not available right now. They expect to have that resolved by the end of the year, but they're working on that and hope to get that resolved soon. And then Amgen, of course, just recently had a delay in its new drug for hyperparathyroidism. It's not clear what the concerns were from the FDA. Amgen has not revealed that, but those are probably the two big stories in terms of drugs in the pipeline. And I think that's my last slide. But certainly if there are any questions, I think I have one more, of course. EF, do you need copies of the slides? I'd be glad to provide those for you. If you have any questions, of course, for me. September was a special month for us because it's our 30th anniversary. So NNI has been around for 30 years. We're very proud of that. And these are, of course, our offerings. E-News 2 times a week, rather. And then we have a month in review e-newsletter. Those are free, of course. We also have a buyer's guide on site, and we also do a print version of that, and, of course, the magazine. So we're glad to have you sign up for those things. If you have any questions for me directly, there's my email address, and thanks very much for listening.
Mark, thanks very much, and congratulations on that anniversary for NNI and your services.
Thank you.
Thank you. It's a really wonderful product that you provide, folks. We are several minutes past the top of the hour, so I think we'll sign off at this point. Again, folks who would like to access the slides, those are available from the website. Thank you so much, and we'll do this again with our next update in 4 months. Thank you. Bye-bye.